Hello, this case study is covering anemia, which is a hematologic disorder. A reminder that anemia is defined as a reduction in the total number of erythrocytes or red blood cells that are circulating within the blood. It can also involve a quality or quantity issue when it comes to hemoglobin. In this case study, we have a 47-year-old male that presents with this gradual onset, so it doesn't come on suddenly, but it seems to take time. This gradual onset of dyspnea, which you should know is shortness of breath when he's exerting himself. So let's say he's trying to climb stairs very quickly, or he's trying to exercise or go for a jog to get to his car quicker, and he experiences shortness of breath. He also complains of fatigue. He also complains of frequent dyspepsia. Dyspepsia is just the fancy term for indigestion. So he has indigestion with nausea and reports occasional epigastric pain. Now, it's unlikely the patient would say that they have epigastric pain, but this is the proper term for somebody who reports pain in the upper abdomen. He also has a history of alcohol abuse. So what I'm providing you here is relevant information relating to this condition of anemia. And remember, anemia really is an umbrella term, and there are various different types and causes of anemia, and so we're going to use the information in today's case study to try to determine what exactly might be the cause of his anemia. The patient reports that his shortness of breath has gotten worse over the past few weeks, which probably is what caused him to finally seek care from his doctor, is that his symptoms were worsening. And when asked, he said he did not have any chest pain, just shortness of breath. He was not experiencing orthopnea. Orthopnea is shortness of breath that occurs specifically when lying flat. So people with orthopnea, they can't lie down flat without having shortness of breath, so they'll tend to sleep in a propped up position in bed. So if a patient does say, I can't seem to sleep unless I'm propped up, that it is likely that they are experiencing shortness of breath when they lie down flat, referred to as orthopnea. But in this particular case, this is not a symptom or a sign. He denies having any edema, so swelling. He denies having a cough, wheezing, or any recent infections. The patient stated that they do have these occasional episodes of hematemesis. Hematemesis is the vomiting of blood, and this occurs after drinking heavily, so in this case, alcohol. Then he will state that after he experiences this vomiting of blood occasionally, then in subsequent days, he'll have several days of darker stools. And the dark stool, the more proper term for this would be melena, M-E-L-E-N-A, which is this dark black tarry feces, which is just associated with some sort of upper gastrointestinal bleed. And as the blood moves through the digestive tract and the body digests it will cause stools to be very dark. The patient reports that they consume 2 6-packs of beer a day and has for the last 8 years, and this occurred since losing his job. So the stress of losing his job and possibly the boredom associated with that has brought on an increase in his alcohol consumption. Patient reports that nothing seems to make his breathing any better, but antacids will help with that upper abdominal pain, that epigastric pain that I described earlier, as well as the dyspepsia, or the acid reflux, or indigestion. Now, the antacids, what exactly is it that they're doing? Well, antacids, think of ant or anti as against acids. So antacids are going to act by neutralizing the acid in the stomach, which helps combat that pain that the patient is experiencing due to acid production. This patient was diagnosed with a duodenal ulcer, so an ulcer within the first part of the small intestine in the past, and he was given 3 drugs at once. And when he was given these 3 drugs at once, he eventually realized, even if it is helping with his pain, if it's too expensive, you can't afford to take them, it's not uncommon for patients to stop. On On physical examination, the patient appeared thin, pale, so has a pallor appearance, which we know can be associated with anemia, and he appears older than what his stated age is. Temperature at 37 degrees Celsius is normal. Pulse is 95, and normal would be anywhere between, so this would be his resting heart rate, would be anywhere between 60 and 100 beats per minute. So it's on the higher end, but still normal. His respiratory rate is 16. This is also considered normal. Normal would be anywhere between 12 and 20 breaths per minute. And once you get over probably 25, it becomes more concerning, but it's normal in his case. And his blood pressure is normal at 128/72. Going back to this pallor that we see with anemia, he does present with pale sclera. The sclera is the white outer layer of the eyeball. So at the front of the eye, it's continuous with your cornea. So it's pale in color. There was no icterus evident. Icterus is the fancy term for jaundice, so yellowing of the skin and mucous membranes. When auscultating, so listening to the lungs, they were clear. And the lungs were also clear to percussion, which is a method of tapping body parts, in this case the lungs, with the finger or the hand, or you can use a small instrument. And it can help determine the presence of or absence of fluid or any solid objects based on sound when you compare to what you should normally hear within the lungs, which we know are filled with air. Physical examination also indicated that there is a 2-6 systolic ejection murmur at the left sternal border. So let's elaborate on this a bit. In anemic patients, a functional heart murmur can occur as blood is flowing more turbulently through the heart valves. And so what I mean by a physiologic murmur is really a functional murmur, one that is primarily due to some physiologic condition, in this case, a reduction in the normal amount of red blood cells, as opposed to a structural defect within the heart. So if you can correct the underlying physiologic condition, then it can also correct the heart murmur. But in terms of going into a little bit more detail of what this means here, there are several ways that a healthcare provider can describe a murmur, and we can classify them or grade them depending on how loud that murmur sounds using a stethoscope. And so grading will be done on a scale, and sometimes it's reported on a scale of 1 to 6, as in this example. So grade 1, for example, would be where you can barely hear it. Grade 2, you can hear it more. So what this is stating is that this person has a grade 2 murmur out of 6. So on a scale of 1 to 6, this patient has a 2 of that 6 possible grades. And then you can also describe a murmur by the stage that it is heard during a heartbeat. So a heart murmur can be described as being a systolic, or which refers to the contraction where there's ejection occurring, or diastolic, which is when the heart is relaxed and filling up with blood. So in this case, it's during the contraction. And it's heard at the left sternal border, which is, if you recall your breastbone or your sternum, on that left side at the border of the sternum is where it was auscultated. On physical examination, moderate epigastric tenderness was noted, and we know that he was complaining of epigastric pain, but an important note here is that there wasn't any rebound tenderness or guarding evidence. So rebound tenderness refers to, if you were to picture a patient lying on their back and then you take your hands and you're palpating their abdomen. And if you push in a particular area down into their abdomen, that might not cause pain. But then when you let go, in some cases, especially when there's fluid in areas in the abdomen where it shouldn't be, that's called rebound tenderness. So as you let go and it rebounds, it causes the fluid to move around. And there wasn't evidence of guarding either. And this is where if you go to press down on an area of the stomach and then the muscles, other muscles in the area instantly guard against that and sort of resist what you're trying to do, that can be indicative of something that is different than what you maybe initially thought. Guarding can be quite common when palpating the appendix in somebody with appendicitis, for example. Finally, physical examination. The stool was sampled and they did a stool guaiac test, and in this case, it was considered a positive test. Now, what is this? Well, a stool guaiac test is going to look for hidden. Sometimes instead of the word hidden, you'll see or hear the word occult, meaning hidden. So it looks for hidden or occult blood within the stool sample. So sometimes stool doesn't look like there's blood in it, but when you do a test, a stool guaiac test, then you can determine if there is in fact blood in it. And out of curiosity, what is guaiac? This is a substance from some plant that's used to coat the test cards that are used during this test. So you put a fecal sample on a guaiac paper, and then they add some hydrogen peroxide, and when there is blood present, which of course there normally shouldn't be, it's going to yield this blue reaction within a very short period, like a second. So let's look at some specific diagnostic tests that were done. Kind of looked at that a little bit with the stool guaiac test. White blood cells can oftentimes indicate whether or not there's an infection present. And in his case, his white blood cell count was normal and his white blood cell differential was also normal. That tells us that, remember that white blood cells, there's a variety of different types of white blood cells, and if certain ones are elevated, it can indicate certain conditions. If other ones are elevated, it can indicate other conditions. But in his case, the overall differential, or the normal amount of each, was normal. His platelets were also normal. Platelets, also known as thrombocytes, the clotting cells. Now, hematocrit. So this here is a flag. Hematocrit, recall, is the ratio of the volume of your erythrocytes, or red blood cells, to the total volume of blood. So having to do with how much red blood cells you have. And in his case, it should be between 40 and 52%. His is low at 29%. And that makes sense when we're talking about anemia, knowing that if his body is producing abnormal red blood cells because of some sort of deficiency, then the body's going to break down through hemolysis those red blood cells at a faster rate than is considered normal. His reticulocyte count is at 5%. A reticulocyte, thinking back to normal anatomy, is an immature erythrocyte, or an immature red blood cell. And they will mature within a short period. Once they're released into the blood, they'll mature into a red blood cell. But in his case, at 5%, you normally want to have your reticulocytes at about 0.5% to 2.5% in healthy adults. But a reticulocyte percentage higher than that, higher than normal, can be a sign of anemia. And in this case, it does make sense. So his body is releasing more immature red blood cells into the blood at a faster rate than is considered normal. Looking at his blood smear, he had a mix of microcytic, so small, hypochromic, so reduced amount of hemoglobin, and he also had larger than normal macrocytic, sometimes called megaloblastic, cells that had the normal amount of hemoglobin. His clotting tests, coagulation tests, were normal. He had an upper endoscopy done. An endoscopy is a non-surgical procedure used to examine a person's digestive tract. So an upper endoscopy can go through the mouth, down the throat, through the esophagus, into the stomach, into the upper part of the small intestine, and can give you an idea of the health of the mucosal lining. And in his case, there was evidence of a duodenal ulcer, which we know he suffered from in the past, 2 centimeters. And there was evidence of a recent bleed, but not an acute bleed. So blood loss, if we're losing blood, it means that we're losing red blood cells at a faster rate than we are producing them. Further testing or additional testing included looking at the serum iron and serum ferritin. Serum, recall, is the component of blood that is neither a blood cell or a clotting factor. So it's really the blood plasma without the clotting factors. And so in this case, his iron was low and his ferritin was low. And this is indicative then of an iron deficiency anemia. So you know what iron is, but what's ferritin? Well, ferritin is not iron, but it's a protein in the body that contains iron. And so since ferritin is the main form in which iron is kind of stored within the body, it reflects the total iron that's available to the body. So we can say then that ferritin is really the best indicator of whether or not somebody is iron deficient. So in this case, he is. His bone marrow biopsy that was done showed that there were megaloblastic changes and a low amount of iron that is stored. Remember that bone marrow also stores iron, and megaloblastic refers to larger than normal cells. I'm going to circle back for a moment to the blood smear that showed both microcytic hypochromic and macrocytic normalchromic red blood cells. When we learned about these, we learned that it was different deficiencies that caused these different states or descriptive terms. And so why does he have both? Well, microcytic hypochromic is what you would typically see with iron deficiency anemia. So it's clear based on more than one thing and the hemorrhaging as well that he is iron deficient. And part of that could be because he's not eating maybe enough iron, but big part about it is if you're bleeding, you're losing iron. Remember that normally when we undergo hemolysis and we break down our red blood cells, we will reuse the iron. We will use it, we will store it, but if you're actively bleeding, then we can't reuse that iron and it just really becomes a waste product. Now, macrocytic normalchromic brings us into the next component, and that is the fact that he also has low serum folate, but his B12 is normal. So both of these states, if there's a deficiency, so pernicious anemia, deficiency in B12, and folate deficiency can both cause red blood cells to become macrocytic, but the hemoglobin is normal, so just larger than normal cells. But in his case, his B12 is normal, but his folate is low. Now, why might his folate be low? Well, one of the things that I spoke about during the lecture is that alcohol impairs the body's process of converting folate to the form that is usable to contribute to the normal development of red blood cells, and we know that this individual is an alcoholic. So in both these cases, these microcytic hypochromic and macrocytic red blood cells are not normal, and the body recognizes that they're not normal, and so hemolysis will occur, the breakdown of red blood cells, these abnormal ones, at a faster rate than we are producing normal, healthy red blood cells. So the key here is going to be treating the duodenal ulcer to prevent the hemorrhaging, possible iron supplementation depending on the person's diet, and correcting their folate levels. And to correct the folate, not just supplementation, but abstaining from alcohol. Now, as a side note, funny enough, alcohol consumption actually increases iron absorption, but clearly not enough in the case of this patient's hemorrhaging to make up for it. Okay, that is the end of this case study. I hope you enjoyed it. Thanks for your time.